Hi, he is an 80-year-old gentleman who has this subluxated cataract with pseudoexfoliation. It's a generalized zonular weakness which is causing this bag to be very weak. He has phacodonosis and iridodonosis, and at the slit lab examination itself, it was relatively obvious that saving the bag is going to be a challenge. So I had prepared myself for an iris claw lens. If there was a possibility of saving the bag, I was also prepared to use the CTR, try to save the bag, and then use a multi-piece hydrophobic lens and try to use the IOL trap technique if at all the zonular weakness were not very severe. So the extent of zonular weakness could be possible for us to assess only intraoperatively. So I was going to take a call whether to save the bag or to remove it and then use the iris claw lens intraoperatively. But I had kept both the options ready, and let's see how things turn out. The surgery is begun by giving posterior subtenance block with 1.5 ml of lignocaine, and then followed by a small conjunctival bleb which is raised with the lignocaine itself. The plan is to perform a manual small incision cataract surgery, then take a call on whether to save the bag or to sacrifice it and then use an iris claw lens. So I'm sitting superiorly and the conjunctival flap is dissected out. Mild cautery is used to stop the bleeders. To stabilize the globe, I usually prefer to make a small scleral groove which I'll be holding with my Hoskin forceps to stabilize the globe as the sclerocorneal tunnel incision is being fashioned. A partial thickness groove is created for the incision, and using a tunnel blade, I'm going to create 6.5 to 7 mm of sclerocorneal tunnel. The capsule is stained and the chamber is pressurized with a dispersive OVD. Time to perform the rhexis. The anticapsule is punctured with the capsulotomy needle, and using a rhexis forceps, the flap is raised and the rhexis is begun. As the rhexis is being created, we can clearly see that there are folds in the anticapsule as it is being torn, suggestive of significant zonular weakness, but I was pleasantly surprised that the rhexis could be performed with not so much of a difficulty as I'd anticipated. So at this moment I was hopeful that I can save the bag, and let's see how things turn out. So the rhexis is done now. Before venturing into hydrodissection, I thought I can stabilize the bag well by using the CTR early. So I'm creating some space within the capsular bag by putting in viscoelastic under the anticapsule, and then the CTR is being threaded into the capsular bag. So in a couple of minutes the CTR is in the capsular bag, and I'm now hoping that the bag is relatively stable and if possible I can just save the bag. So the hydrodissection is now being attempted. It's quite difficult to perform the hydrodissection in these eyes with extremely loose zonules. Nevertheless, when I'm trying to decompress the bag by tapping the nucleus down after the hydrodissection, I can clearly see that the entire bag is moving and I'm unable to let out the trapped fluid. So it's clearly indication that the zonular health is not great at all. Even after using the CTR, the 360 degrees generalized laxity of the zonules is quite profound. So now I'm having a doubt that it might not be possible to save the bag, and maybe I had to resort to sacrificing the bag and then putting in an iris claw lens. Now is the time to extracting the nucleus out. So I'm still having some faint hope that I can possibly deliver the nucleus out without compromising the bag, using the bimanual technique wherein the two syncytials are introduced to lift up the equator of the nucleus, and then the nucleus is gently wheeled out of the capsular bag. So you can see that there is enough resistance and the bag is wanting to come along with the nucleus itself, because there's hardly any countertraction by the zonules. Well, it was not easy to maneuver the nucleus out. Nevertheless, a nucleus alone could be maneuvered out of the bag with the capsule bag still being intact. The dense nucleus needs to be extracted out through this incision. Again, OVD is injected to protect the endothelium. Using the phaco sandwich technique, the nucleus is firmly gripped between the vectus and the dialer, and then the entire nucleus complex is gently pulled out of the eye. Some of the fragment is broken and stuck at the tunnel area. This small piece of nucleus and some of the epinucleus is passively expressed out using viscoelastic. Gentle irrigation is being done to clear off some of the muck which is coating onto the endothelium of the cornea, the viscoelastic and the lens matter. And now is the time to aspirate the cortex out. Well, it's very obvious now that the zonules are profoundly weak. The bag is moving around everywhere, and as I'm trying to aspirate the cortex, you can see that the bag is really moving around. At this point, it's quite obvious that the bag is not going to be stable, and it is definitely not wise for me to consider implanting a posterior chamber lens with whatever way unless I stabilize the bag with the CT segments. The other option is always to do a glued IOL or some form of scleral fixation of the lens. But in this case, I would prefer to do an iris fixated lens. So that is my original plan. So now is the time for me to remove the bag. I'm just going to inject some viscoelastic under the bag. I can see that the equator bag is being prolapsed into the antechamber and the CTR is also seen. So my plan is to remove the CTR along with the bag itself. I'm using this forceps to grab the CTR and pull it out and expect the bag to come along with it. The CTR is pulled out, but the bag still remains there. So I'm again going to go ahead with the capsulorhexis forceps, grasp the flimsy bag and then pull it out. And now is the time to perform antivitrectomy before placing the iris claw lens. I'm going to use diluted triamcinolone acetate to stain the vitreous. Bimanual antivitrectomy is being performed. In a matter of few minutes, minimal antivitrectomy is performed. Intracameral pilocarpine is used to constrict the pupil. Using the same vitreous cutter, I'm going to do an peripheral iridectomy. I'm choosing the inferior quadrant because the visibility is not so great in the superior quadrant. I prefer to use the IA cut mode with a very low cut rate here. That is irrigation, aspiration and then cut mode. These are the settings for the IA cut mode, and I have a nice little iridectomy done there. Before putting in the lens, I just want to ensure that there's no vitreous around the vicinity of the pupil and the iris. So I'm just going in with my cutter to clear off any possibility of any vitreous there. I'm creating two new fresh paracentesis incisions, which are more of a limbal stab incisions, which are exactly 180 degrees away from each other, which are going to be used for enclaving the iris claw lens. So I'm not using the original side ports because they are not exactly in the position where I want, and they also have a little bit of a corneal length inside. So it might be difficult for me to reach and tuck the iris. So that's the reason I made a fresh pair of stab incisions which have got very small corneal length. Iris claw lens is gently introduced into the eye in a vertical orientation, and then it is rotated to ensure that both the haptics are in the horizontal meridian, that is 3 and 9 o'clock meridian. And using this iris claw lens forceps, the lens is grasped and one haptic goes behind the iris, and then I'm using a 26G cannula to go through the side port and just to tuck the iris into that slit of the haptic. There is some amount of bleed which is happening. Now before leaving the forceps, I want to ensure that the enclavation has happened correctly. So what I do is, with the forceps, I move the lens sideways so that I can see the iris also moving sideways. This confirms that the iris enclavation has happened in the haptic. I come out, re-inject viscoelastic, and then the hands are switched. The lens is again grasped now with my left hand. The second haptic is now gone behind the iris. And again using the 26G cannula, the iris is enclaved into the slit of the second haptic. You can see that the enclavation has happened properly, and I leave the forceps. Now the lens looks to be very stable. I go in with my irrigation cannula to flush out all the blood which has entered the antechamber. I'm going to use vitrector to go behind the lens and remove some of the OVD which has gone inside, and also do a limited anti-vitrectomy. And once it is done, time to close. As I'm hydrating through my left side port, I see a small wave. This is possibly a Descemet membrane detachment to the side port. There's a reason why I'm going to put in air to provide some tamponade to this area. To prevent post-operative against stigmatic drift, I'm going to use a single radial suture at 10 o'clock position. I'm using this steno nylon suture to achieve that. I ensure that the air is complete in the antechamber. Intracameral antibiotics are placed. That's it, the case is done. This is the next day post-op picture, and these are the third day post-op picture. The pressure is around 20 and she's on anti-glaucoma medication. Patient vision is uncorrected 612 and this is his refraction. Thank you so much for watching and hope you found this helpful.